Welcome to Chapter 18. Here we will discuss intraoperative nursing management. This is found in your text on page 420. Please do review the glossary and familiarize yourselves with the terms that will be found throughout this chapter. When looking at members of the surgical team, note that the surgical team consists of the patient, the anesthesiologist, which is the physician, or the anesthetist, which is the CRNA, the surgeon, nurses, surgical technicians, and the registered nurse first assistants, or certified surgical technologists, which are also your assistants. The anesthesiologist or CRNA administers the anesthetic agent and monitors the patient's physical status throughout the surgery. The surgeon, nurses, and assistants scrub and perform the surgery. The person in the scrub role, either a nurse or a surgical technician, provides sterile instruments and supplies to the surgeon during the procedure by anticipating the surgical needs as the surgical case progresses. The circulating nurse coordinates the care of the patient in the OR. Care provided by the circulating nurse includes planning for and assisting the patient, positioning, preparing the patient's skin for surgery, managing surgical specimens, anticipating the needs of the surgical team, and documenting intraoperative events. Note that collaboration of the core surgical team using evidence-based practices tailored to the specific case results in optimum patient care and improved outcomes. When we look at the individual patient, when they enter the OR, they may feel either relaxed and prepared or fearful and highly stressed. These feelings depend to a large extent on the amount of timing of the preoperative sedation, education, and the individual patient. The patient is also subject to several risks: infection, failure of the surgery to relieve symptoms or correct a deformity, temporary or permanent complications related to the procedure or the anesthetic agent, and death. These are uncommon but potential outcomes of the surgical experience. When we look at the circulating nurse, this is also known as the circulator. This is a qualified registered nurse who works in collaboration with surgeons, anesthesia providers, and other healthcare providers to plan the best course of action for each patient. In this leadership role, the circulating nurse manages the OR and protects the patient's safety and health by monitoring the activities of the surgical team, checking the OR conditions, and continually assessing the patient for signs of injury and implementing appropriate interventions. A foremost responsibility includes verifying consent. If not obtained, surgery may not be commenced. The team is coordinated by the circulating nurse, who ensures cleanliness, proper temperature, humidity appropriate, lighting, safe function of equipment, and availability of supplies and materials. They also monitor aseptic practices to avoid breaks in technique while coordinating the movement of related personnel. In addition, the circulating nurse is responsible for ensuring that the second verification of surgical procedure and site takes place and is documented. When we look at the scrub role, the registered nurse, licensed practical nurse, or surgical technologist performs the activities of the scrub role. These include performing a surgical hand scrub, setting up the sterile tables, preparing sutures, ligatures, and special equipment. As far as the surgeon goes, they perform the surgical procedure, heads the surgical team, and is a licensed physician, being an MD or a DO, oral surgeons, or podiatrists who have specially trained and been qualified. As far as your registered nurse first assistant, this is another member of the OR team. Although the scope of practice for this depends on each state's Nurse Practice Act, they practice under the direct supervision of the surgeon. Their responsibilities include handling tissue, providing exposure, at the operative field, suturing and maintaining homeostasis. The role requires thorough understanding of anatomy and physiology, tissue handling, and principles of surgical asepsis. They must also be aware of the objectives of the surgery, must have the knowledge and ability to anticipate needs, and work as a skilled member of the team. They must also be able to handle any emergency situations in the OR. As far as the anesthesiologist or the CRNA, the anesthesiologist, of course, is your physician, and they are specially trained in the art of science of anesthesiology. The anesthetist, which is in our role, this is a nurse that has been qualified and specially trained who administers anesthetic medications. Of course, again, most CRNAs are nurses who have a master's degree. And you want to note when the patient does arrive to the OR and the anesthesiologist or the CRNA reassesses the patient's physical condition immediately prior to initiating that anesthesia. Once that is done, then the anesthetic agent is administered and the patient's airway is maintained through an intranasal intubation. This is if the surgeon is using an oral approach to surgery. Intubation with an endotracheal tube or an ETT tube or laryngeal mask airway, which is your LMA, can also be used. During surgery, the anesthesiologist or CRNA monitors the patient's blood pressure, pulse, and respirations, as well as the ECG, blood oxygen saturation level, tidal volume, blood gas levels, blood pH, alveolar gas concentrations, and body temperature. When looking at the gerontologic considerations, of course we want to consider that population of people. Approximately 1/3 of the surgical patients are 65 years of age or older as the baby boomer population enters the geriatric years. There's a progressive loss of skeletal muscle mass in conjunction with an increase in adipose tissue. Comorbidities, advanced systemic disease, and increased susceptibility to illness, even in the healthiest geriatric patient, can complicate perioperative management. Age alone confers enough surgical risk that it is clinical predictor of cardiovascular complications. Lower doses of anesthetic agents are required in the older adults due to decreased tissue elasticity, especially in your lungs and cardiovascular systems. Older patients often experience an increase in duration of clinical effects of medications. In addition, body tissues of the older adult are made up of predominantly water, and those tissues which with a rich supply such as skeletal muscle, liver, and kidneys shrink as the body ages. When we look at caring for this population, throughout surgery, the nursing responsibilities will include providing for the safety and well-being of the patient, coordinating the OR personnel, and performing scrub and circulating activities. As patient advocates, intraoperative nurses monitor factors that have the potential to cause injury, such as patient position, equipment malfunction, and environmental hazards, and protect the patient's dignity and interests while the patient is under anesthesia. Cultural, ethnic, and religious diversity are important considerations for all healthcare professionals, not just the geriatric population. Nurses in the perioperative area should be aware of medications that may be prohibited by certain groups, such as Muslims and those of Jewish faith cannot use procrine-based products such as heparin. Buddhists may choose not to use bovine products. In certain cultures, the head is a sacred area and the staff should allow patients to apply their own surgical cap in this case. Here's a true or false statement in regards to the circulating nurse. And here's the answer with the rationale. Now, when we're talking about the intraoperative experience, we want to very well prevent infection. That is one of our main goals. I do want you to take a look at figure 18-1. It is in your text on page 423. Within this is a sample surgical safety checklist. And this is the first edition, so they may differ from hospital to hospital or from OR to OR. But it is basically a checklist that the OR circulating nurse goes over, or the registered nurse first assistant goes over, and they basically do a timeout. They make sure the patient is identified, they have the right site, that they're doing the right procedure, and that, of course, the consent is signed. Of course, if they're operating on a specific site that there's more than one of, we want to make sure that it is marked correctly. Anesthesia safety is checked, any anticipated critical events. They make sure if the patient has any allergies. So in your text, you see a sign in, a timeout, and a sign out. So the sign out is actually important as well. I know you guys may have heard when they left some laps in a patient or some rags in a patient, and the patient ended up dying. So this is why this is so important. This needs to happen before the patient is closed up, before the patient leaves the OR, because then it all goes downhill from there. So that is one of our main goals, to prevent that infection. So when we're looking at that surgical environment, it is known for its dark appearance and its cool temperature. I can tell you the ORs I've been in the last month or so, the temperature is set at 68. Some of the ORs are set at 65. They are very cool. And there are signs all over the room not to change the temperatures. So we do have to look at that when, we're going into the OR. Now, granted, you will have on a million things, so you won't have to worry about being cold. For me, I'm always hot, so even in there, I'm still hot. So to provide the best possible conditions for surgery, the OR is situated in a location that is central to all supporting services, such as your pathology, x-ray, and lab. The OR has special air filtration devices to screen out contaminating particles, dust, and pollutants. To help decrease microbes, the surgical area is divided into 3 zones. The unrestricted zone, where street clothes are allowed. The semi-restricted zone, where attire consists of scrub clothes and caps. And the restricted zone, where scrub clothes, shoe covers, caps, and masks are worn. The surgeons and other surgical team members wear additional sterile clothing and protective devices during surgery. Now, I work in the OR when I go to C-sections for deliveries. And let me just tell you, we have on a hat, we have to do a 3-minute scrub, we have to put on a sterile gown, we have to put on sterile gloves, we have a sterile blanket that we have to catch the baby with, we have on masks, and we have on booties. So we are clothed from head to toe. So that would be in that restricted zone. Now, also, and these are just examples so that you can get a feel of the difference. For the semi-restricted zone, this is the area where we have our warmer for our infant once they come out. So in that zone, all we have to have on is a hairnet and a mask. We don't have to have on, you know, special gowns or anything like that. We can set up our warmers and all of that stuff. So just be aware when you are going into the OR what type of zone you're in. Now note that masks are to be worn at all times in the restricted zone in the OR. Headgear should be completely covering the hair. Barriers such as scrub attire and masks do not entirely protect the patient from microorganisms, upper respiratory tract infections, sore throats, and skin infections in staff and patients are sources of pathogens and must be reported. So usually when you're sick, they don't want you in their OR, basically. So when we look at the principles of surgical asepsis, this prevents the contamination of surgical wounds. The patient's natural skin flora or previously existing infection may cause postoperative wound infections. Rigorous adherence to the principles of surgical asepsis by OR personnel is basic to preventing the surgical site infections. All surgical supplies, instruments, needles, sutures, dressings, gloves, covers, and solutions that may come in contact with the surgical wound or exposed tissues must be sterilized before used. Surgical team members wear long-sleeve sterile gowns and gloves, and an area of the patient's skin larger than that requiring exposure during surgery is meticulously cleaned, and an antiseptic solution is applied. So when you start going on your maternity rounds and you do end up in a C-section, you should see them meticulously clean the abdomen with that antiseptic solution. Even when they're operating, let's say, on a knee or even a hip, they're going to meticulously clean that area. And for some surgeries, they have the patient bathe with an antiseptic solution the morning of surgery. So just be aware of that as when you're looking at that as well. Note that when we're looking at the environmental controls, in addition to the protocols described previously, surgical asepsis requires meticulous cleaning and maintenance of the OR equipment. All equipment that comes into direct contact with patients must be sterile. Sterile linens, drapes, and solutions are used. Instruments are cleaned and sterilized in a unit near the OR. Airborne bacteria are of a concern. To decrease the amount of bacteria in the air, standard OR ventilation provides 15 air exchanges per hour, at least 3 of which are fresh air. When we look at the basic guidelines to surgical asepsis, all practitioners involved in intraoperative phase have a responsibility to provide and maintain a safe environment. Adherence to aseptic practice is part of this responsibility. Now we'll go over some basic principles for aseptic technique. All materials in contact with the surgical wound or used within the sterile field must be sterile. Sterile surfaces or articles may touch other sterile surfaces or articles and remain sterile. Contact with unsterile objects at any point renders a sterile field being contaminated. Gowns of the surgical team are considered sterile in front, from the chest to the level of the sterile field. The sleeves are considered sterile from 2 inches above the elbow to the stocking cuff. Sterile drapes are used to create a sterile field. Only the top surface of the draped table is considered sterile. During draping of the table or patient, the sterile drape is held above the surface to be covered and is positioned from front to back. Items are dispensed to a sterile field by methods that preserve the sterility of the items and the integrity of the sterile field. After a sterile package is opened and the edges are considered unsterile, sterile supplies, including solutions, are delivered to a sterile field or handed to a scrubbed person in which a way that the sterility of the object or fluid then remains intact. And in figure 18-2, you see, I just actually talked about it, they're actually performing a C-section, and that is the draping that is provided for the patient. I wish they would have provided another photo that would have shown you the meticulously cleaning procedure that they do for the abdomen, and there's actually a clear drape on the patient as well that you cannot see. Continuing to look at that surgical asepsis, the movement of the surgical team are from sterile to sterile areas and from unsterile to unsterile areas. Scrub people and sterile items contact only sterile areas. Circulating nurses and unsterile items contact only unsterile areas. Movement around a sterile field must not cause contamination of that field. Sterile areas must be kept in view during movement around the area. At least 1 foot distance from a sterile field must be maintained to prevent inadvertent contamination. It is very easy to contaminate a sterile field without knowing it. Merely touching the bed with your scrubs has then contaminated everything on that bed. So then they have to start all over. This is why, most, and I say most lightly, areas in the OR are so restricted. So, whatever a sterile barrier is breached, the area must be considered contaminated. A tear or puncture of the drape permitting access to an unsterile surface underneath renders the area unsterile as well. This can be a drape or something like that, and it must be replaced if that does happen. Every sterile field is constantly monitored and maintained. Items of doubtful sterility are considered unsterile. Sterile fields are prepared as close as possible to the time of use. So, just like in figure 18-2, they took this woman in, and all of this sterile field was created literally within minutes before the operation occurred. She wasn't in there for hours laying in this sterile field and these drapings and being clean. This literally happens right before surgery takes place. And this helps cut down on breaking that sterile field. The routine administration of hyperoxia or high levels of oxygen is not recommended to reduce the surgical site infections. Okay, so now we'll look at some anesthetic agents. I will point out some important ones, anything that I do want you to particularly look at. I don't want you guys to try to memorize all of these. We will just discuss them briefly. And the first one, of course, we'll look at is general anesthesia. Of course, before even going into anesthesia, you must understand what it actually is. So note that anesthesia is a state of narcosis. What this means is severe central nervous system depression produced by a pharmacologic agent. Analgesia, relaxation, and reflex loss. The patient under general anesthesia, they are not arousable, not even to the painful stimuli. And I know we talked about it in class, the sternal rub. They won't even respond to that when they're under general anesthesia. They lose the ability to maintain their ventilated functions and require assistance in maintaining a patent airway. Cardiovascular function may also be impaired. So note that with general anesthesia, it does consist of 4 stages, each associated with a specific clinical manifestation. So stage 1 is the beginning anesthesia, stage 2 is excitement, stage 3 is surgical, and then stage 4 is the medullary depression. I don't want you guys to have to memorize all of that. I just want you to know that there are, of course, 4 stages. When we look at inhalation, Inhaled anesthetic agents include volatile liquid agents and gases. They produce anesthesia when their vapors are inhaled. Some commonly used inhalant agents, they are listed in your text on page 428 in table 18-1. Gas anesthetic agents are administered by inhalation and are always combined with oxygen. Nitrous oxide is the most commonly used gas anesthetic agent. Looking at intravenous administration, general anesthesia can also be produced by IV administration of various substances such as barbiturates, benzos, non-barbiturate hypnotics, dissociative agents, and opioid agents. An advantage of IV anesthesia is that the onset of anesthesia is pleasant. There is none of the buzzing, roaring, dizziness known to follow administration of inhalation anesthetic agents. The duration of action is brief and the patient awakens with little to none when we talk about nausea and vomiting. And we'll talk about some of those side effects soon. Another one is regional anesthesia. In regional anesthesia, an anesthetic agent is injected around the nerve so that the region supplied by these nerves is anesthetized. The effect depends on the type of nerve involved, of course. The patient receiving regional anesthesia is awake and aware of his or her surroundings unless the medications are given to produce mild sedation or to relieve anxiety. Because depending on some of the procedures that are done, this can cause a lot of anxiety in the patient. So we want to make sure that we know what is being given to the patient. And this is helpful also for OB. You want to know what the anesthesiologist is giving your patient because it can do what in turn? Affect the baby. So these are just things you want to know, especially when it comes to anesthesia. Looking at epidural anesthesia, it is achieved by injecting a local anesthetic agent into the epidural space that surrounds the dura mater and the spinal cord. The administered medication diffuses across the layers of the spinal cord to provide anesthesia and actual pain relief. An advantage to this is the absence of a headache that can result from spinal anesthesia. A disadvantage is the greater technical challenge of introducing the anesthetic agent into the epidural space rather than the subarachnoid space. If inadvertent puncture of the dura occurs during epidural anesthesia and the anesthetic agent travels toward the head, high spinal anesthesia can result. This can produce severe hypotension and respiratory depression and even arrest. Treatment of these complications includes airway support, IV fluids, and the use of vasopressors. So, you have some complications to all of these, but now you can see how some of them affect the patient and how some of them can be a little more tricky than others. When we look at spinal anesthesia, this is an extensive conduction nerve block that is produced when a local anesthetic agent is introduced into the subarachnoid space at the lumbar level, usually between L4 and L5. It produces anesthesia of the lower extremities, perineum, and lower abdomen. For the lumbar puncture procedure, the patient usually lies on their side in the knee chest position. The spread of the anesthetic agent and the level of anesthesia depend on the amount of agent injected, the speed in which it is injected, and the positioning of the patient after the injection, and the specific gravity of the agent. If the specific gravity is greater than that of the CSF or the cerebral spinal fluid, the agent moves to the dependent position of the subarachnoid space. If it is less, the anesthetic agent moves away from the dependent position. Of course, the anesthesiologist or the CRNA will control this administration, and a few minutes after induction of a spinal anesthesia and paralysis affect the toes and perineum, then gradually the legs and the abdomen. If it reaches the upper thorax and cervical spinal cord in high concentrations, a temporary, partial, or complete respiratory peristalsis results. Nausea, vomiting, and pain may occur during surgery when spinal anesthesia is used. As a result, these reactions result from manipulation of structures within the abdominal cavity. Adequate hydration and administration of IV of appropriate medications may prevent such reactions. In your text on page 430 and 431, Table 18-2 goes over some commonly used intravenous medications. You also want to note that headache may be an after effect of spinal anesthesia. This is something that you will get with spinals versus with epidurals. So that's something to weigh in when your patient has a spinal versus an epidural or vice versa. And then on page 432 in your text, Table 18-3 goes over the selected regional and local anesthetic agents, just some of the ones that are used typically, their advantages and disadvantages. And Figure 18-4 goes over some injection sites for spinal and epidural anesthesia, and you can see how difficult it is to actually get in that little space. So it does take a lot of practice and a very skilled, detail-oriented person to do that. Now we'll look at some of the complications that can occur. First, let's look at anesthesia awareness. Publicity has increased patients' concern about intraoperative awareness. It is important to discuss awareness with patients preoperatively so that they realize that the only general anesthesia is meant to create a state of oblivion. All other forms of anesthesia will eliminate pain, but sensation of pushing and pulling tissues may be recognized and may hear conversations among the operative team. In many cases, they may be able to respond to questions and involve themselves in the discussion. This is normal, and it's not what is referred to as anesthesia awareness. Unintended intraoperative awareness refers to a patient becoming cognizant of surgical interventions while under general anesthesia and then recalling the incident. Neuromuscular blocks sometimes required for surgical muscle relaxation intensify the fear of the patient experiencing awareness because they are unable to communicate during the episode. The frequency of anesthesia awareness may be as high as 0.1% to 0.2% of the general anesthesia patients, equivalent to about 30,000 cases per year in the U.S. Indications of occurrence of anesthesia awareness include an increase in blood pressure, rapid heart rate, and patient movement. However, hemodynamic changes can be masked by the paralytic medications, beta blockers, and calcium channel blockers. Thus, the awareness may remain undetected. Pre-medication with anesthetic agents or amnesthetic, which is those medications that give you amnesia and avoidance of muscle paralytics, except when essential, help to preclude the occurrence. So this is a very scary thing. It is basically like the patient is fully awake and can feel everything, but they cannot move and they cannot say anything. So it's like you're trapped inside your body and you cannot get out. And there is a movie out there, and I believe the name of it is called Anesthesia. It is very crazy. After I saw that movie, I did not want to have surgery for anything that involved general anesthesia. I'm like, they're going to put me out and it's not going to work. And this is a little off topic, but it does refer to anesthesia awareness. Within the movie, just to give you a glimpse of like what actually occurs, this particular patient was actually having cardiovascular surgery. Can you believe it? So not only did they have to crack open his sternum with a saw, basically, they were in there touching his heart, sewing up stuff, cutting stuff, and he could feel everything. So just imagine that pain. And his eyes were moving, but they were closed. So it was like you have rapid eye movement while you're sleeping. So, of course, the anesthesiologist or the CRNA wasn't paying any attention. They kind of like listening to their music, doing their thing. And blood pressure was fine because they had given him something to basically paralyze him. And a muscle relaxer. Also, they gave him, they gave him a few things. So he was out. Well, he was supposed to be out, but he could feel everything. And the only time they could tell that he was awake was that the pain was so bad as they were in there messing with his heart that one tear fell out of his eye, like rolled down the side of his face. And that is so crazy. But they still did not know because of the simple fact that the CRNA wasn't paying any attention. So, that's some crazy stuff. But it rarely happens. But 30,000 cases a year is quite a lot. So, that is something to think about. And go get the movie if you have not seen it. It is very crazy. So, another common thing, anesthesia awareness is not so common. One of the common things is nausea and vomiting, of course. So nausea and vomiting or regurgitation may affect patients during the intraoperative period. If gagging does occur, the patient is turned off to the side, the head is of the table and lowered, and a basin is provided to collect any vomit. Suction is then used to remove saliva and vomited gastric contents. This is why they tell you not to eat before you go to surgery. In some cases, the anesthesiologist or anesthetist can administer antiemetics preoperatively, but this is really why they tell you not to eat or drink prior to surgery. Usually, if you're having surgery in the day, they tell you don't eat anything after midnight. Some patients can, depending on what type of surgery, they allow patients to drink small amounts of water or fluids up until 4 hours before surgery. So just kind of see where your facility is as far as eating and drinking. Anaphylaxis is another complication. Anytime a patient comes into contact with a foreign substance, there is a potential for an anaphylactic reaction. Because the medications are the most common cause of anaphylaxis, intraoperative nurses must be aware of the type and method of anesthesia used, as well as the specific agents. Latex allergies, the sensitivity to the natural rubber latex products has become more prevalent, creating the need for alert responsiveness among healthcare professionals. I can give you an example firsthand. I am allergic to the IV catheters at a particular hospital. I am not sure what they're made with. I did not know that I was allergic to any type of latex or tape or anything like that. But I've had a few of them, and as soon as they were in, they were hurting, burning. My veins turned hard as rocks. Severe itching, burning. It was just not okay. So that wasn't anaphylaxis, but that was kind of like my equivalent to a latex allergy. So, you want to make sure you're asking these people about their allergies. Another one is hypoxia and other respiratory complications. Inadequate ventilation, occlusion of the airway, inadvertent intubation of the esophagus, and hypoxia are significant potential complications that are associated with anesthesia. Another thing is hypothermia. During anesthesia, the patient's temperature may fall, glucose metabolism is reduced, and as a result, metabolic acidosis may develop. This condition is called hypothermia and is indicated by the core body temperature that is lower than the normal 98 or less. Inadvertent hypothermia may come as a result of a low temperature in the OR, infusion of cold fluids, inhalation of cold gases, open body wounds or cavities, decreased muscle activity, advanced age, and pharmacological agents such as your vasodilators and general anesthetic medications. Unintentional hypothermia needs to be avoided. If it does occur, it must be minimized or reversed. If it is intentional, the goal is safe return to normal body temperature. Environmental temperature in the OR can temporarily be set to about 78 to 80. IV and irrigating fluids are warm to 98.6 degrees. And usually they may do this when they're cooling the person off, but you don't want to cool them off too fast, or if the patient is having some type of, transplant, they may cool the body down and put the patient in an induced hypothermia. So that is intentional. We don't want it to be unintentional. One of the major ones to look at is malignant hypothermia. So we want to distinguish between the both of those as well, and really note the difference. So with your malignant hypothermia, it is a rare, often inherited muscle disorder that is chemically induced by anesthetic agents. It can be triggered by myopathies, emotional stress, heat stroke, neuroleptic malignant syndrome, strenuous exercise exertion, and trauma. Of course, your clinical manifestations for this are related to the cardiovascular and musculoskeletal activity. Tachycardia, being that a heart rate would be greater than 150, is often the earliest sign. Sympathetic nervous stimulation also leads to ventricular dysrhythmias, hypotension, decreased cardiac output, oliguria, and later cardiac arrest. The rise in temperature is actually a late sign that develops rapidly. Body temperature can increase 1 to 2 degrees Celsius every 5 minutes, and the core body temperature can exceed 107 degrees Fahrenheit. That is insane. So please be on the lookout for both hypothermia and malignant hyperthermia. So one is patient's cold, and one's the patient's like on fire. So when we look at managing that, of course you want to recognize the symptoms early and discontinue anesthesia properly. That would be imperative. Goals of treatment are to decrease metabolism, reverse metabolic and respiratory acidosis, correct dysrhythmias, decrease the body temperature, provide oxygen and nutrition to the tissues, and correct the electrolyte imbalances. So you may see these people with cooling blankets on. They may be on. They may have bags of ice on. So we've seen some crazy stuff go on when we're trying to cool these patients off. Of course, it is uncommon, but as the nurse, you must identify those patients that are at risk, recognize any signs or symptoms, and have appropriate medication and equipment available, and just, of course, be knowledgeable about the whole process. And then as far as DIC and infection, of course, infection is your big thing that you would look at. And DIC you will cover in-depthly in maternity, so I won't too much dive into that, but that is a condition that you will cover. But that is one of the risks after surgery. And more so with your pregnant women, and they don't have to be pregnant to have DIC. but it does occur with that population more often than not, especially your C-section patients. And here's a true or false statement in regards to general anesthesia and bradycardia. And here's the answer with the rationale. So here is just a small list of adverse effects of surgery and anesthesia, and you can refer back in your text to table 18-2 that goes over some of those drugs and some of those disadvantages, which could be some of your adverse effects that occur when using that medication. Of course, the big ones that we look at, of course, are your allergies, dysrhythmias, hypotension. We can pretty much address readily. Thrombosis is another big one. So even in the OR, they put on they may, depending on what they're operating on, they usually put on the SCDs or the sequential compression devices that helps with circulation in the lower extremities while the patient isn't moving, especially if they're going to be doing long surgeries. I'm sure you guys have watched Grey's Anatomy, and you can see that, if they're doing, a 6-hour brain surgery, this patient needs to have on some anti-embolytic stockings to prevent thrombosis or those SCDs. They will also be getting fluids to prevent, that hypotension from going on. We want to make sure our anesthesiologists, or shall I say our respiratory therapists, who may be going in and putting in that tube, our anesthesiologist needs to monitor it. We want to make sure we're looking for those changes. Here's a question in relation to general anesthetics and how they're eliminated. And here is the answer with the rationale. And then to finish up this chapter, we'll look at the nursing process and what actually needs to be done for the patient during surgery. So as an intraoperative nurse, we focus on the nursing diagnosis, interventions, and outcomes that surgical patients and their families experience. Additional priorities include collaborative problems and expected goals. So, of course, we want to make sure we do a thorough assessment, get those nursing diagnoses kicked out there, one of which can be anxiety. So we want to reduce that anxiety. Of course, making sure those allergies are under control. And usually if the patient has a latex allergy, they can have other equipment that is available so that that patient does not have a reaction. We want to look at positioning, and we will go over that in a few minutes. And then risk for injury related to anesthesia or the surgical procedure. We want to prevent our patients from having any type of injury. And of course, disturbed sensory perception. That can be sometimes for your older population. When they come to, they may be a little confused. So when we look at first reducing that anxiety, of course the OR can seem cold, stark, and frightening to the patient, who may be feeling isolated and apprehensive. Of course, introduce yourself, address the patient by name, and frequently verify details, provide explanations, and encourage and answer questions to provide a sense of professionalism and friendliness. This can decrease that anxiety. When discussing what the patient can expect in surgery, the nurse uses basic communication skills such as touch and eye contact if it is culturally accepted by that person, and this helps to reduce anxiety. Of course, again, latex allergies require that early identification and communication to all the personnel so everybody knows no one should be wearing latex if the patient is allergic, because we do not want any reactions to occur. So, in most ORs, there are a few latex items currently being used, but because there are still some, maintenance of the latex allergy precautions throughout the perioperative period must be observed. Of course, looking into those other complications, we want to make sure, as the nurse, it is our responsibility, particularly pre-anesthesia and as a perioperative nurse, to be aware of latex allergies, necessary precautions, and products that are latex free. Hospital staff are also at risk for development of latex allergies secondary to repeated exposure to those latex products. So even though you weren't allergic before, which I think that has happened to me, seeing that I've been in the setting for so long and I've dealt with these materials for such a long time, that I've developed this allergy. And I didn't know that. So this is a good thing to know. And this not only applies to latex, but other things as well, other drugs, foods, and things of that nature. So here in your text on page 437, it goes over some positioning. And we'll briefly review each position and what they can be used for. So when we look at positioning, there are certain factors that you want to consider. The patient should be in a comfortable position as possible, whether they are conscious or unconscious. Just because they're unconscious, that doesn't mean you can flip them upside down and turn them around and put them in a U shape. They still need to be comfortable even if they're unconscious, okay? The operative field must be adequately exposed depending on what they're operating on. An awkward position, undue pressure on the body part, or the use of stirrups or traction should be or should not obstruct the vascular supply. So you can see, like in figure C, they have, the patient in a lithotomy position. This should not be obstructing their vascular supply. And you see, even in the picture, the patient looks as though they have thigh-high anti-embolytic stockings on. So, common sense. Respiration should not be impeded by the pressure of arms on the chest or by a gown that constricts the neck or the chest. We don't want our patient choking, okay? Nerves must be protected from undue pressure. Improper positioning of arms, legs, feet can cause serious injuries and paralysis, so we want to avoid that. Shoulder braces must be well padded to prevent irreparable nerve injury, especially when in the Trendelenburg position. This is necessary. Precautions for the patient's safety must be observed, particularly in the older adult population, patients who are thin or obese, and those with physical deformities. Patients may need light restraint before induction of the case. The usual position for surgery, called the dorsal recumbent position, is flat on the back. Both arms are positioned at the side on the table, with one arm hand placed palm down and the other carefully positioned on an arm board to facilitate IV infusion of fluids, bloods, or medications. The Trendelenburg is usually used for surgery on the lower abdomen and pelvis to obtain good exposure by displacing the intestines into the upper abdomen. So it kind of flips the patient up towards their head, but you're not going to flip them completely, okay? It flips those intestines there. and that is in figure 18-5. That is picture B. So picture A shows you what your dorsal recumbent is, and they have the one arm palm up, and then the one would be palm down on the other side. Then we look at the lithotomy position, which is figure C. This is used for nearly all perineal, rectal, and vaginal procedures. The patient is positioned on their back with the legs and thighs flexed. The position is maintained by placing the feet in the stirrups. Otherwise, your patients will not be able to hold their legs up like that for that long. Then the Sims or lateral position is usually used for renal surgery, and that is figure D in figure 18-5. So just so that you get an idea of how these actually look, that will help you a little better to understand what they are and what they're used for. And again, we just covered those positions and what to consider when looking at those positions. And then lastly, we want to talk about protecting that patient from injury. That's one of our main things as well, just as high on the ladder as preventing that infection. So, of course, various activities are used to address the diverse patient safety issues that arise in the OR. The nurse protects the patient from injury by providing a safe environment, verifying information, checking the medical record for competencies or completeness, and maintaining surgical asepsis and an optimal environment are critical nursing responsibilities. A surgical checklist is used prior to the induction of anesthesia, before the skin incision is made, and before the patient leaves the OR. And usually it is before they even close up the patient. They are counting their lap pads, they're counting their instruments to make sure, they have not left them in the patient. So, it is important to review the patient's record for correct informed surgical consent with the patient's signature. Make sure the patient has signed the consent. Sometimes when your secretaries or your unit clerks make the chart, they'll put consents with the patient's label on there in the chart. And unknowingly, if no one has really looked at the consent, they will think it is signed just because they see it in the chart. Now, most healthcare facilities have told or, informed their clerks to not put blank forms in the chart because that has led to some craziness happening. It can lead to the patient getting all the way to the OR and they're doing their timeout, to make sure the patient has a consent and it's not signed. So, we want to make sure that those things are done. And usually the surgeon pretty much flips through the chart as well before they get the patient down in the OR. That's just kind of like the worst case scenario if that happens. So make sure they have completed records of the health history and physical exam, results of their diagnostic studies, any allergies. Make sure you include that latex. In addition to checking all that necessary patient data is complete, the perioperative nurse obtains necessary equipment specific for the procedure. The need for non-routine medications, blood components, instruments, and other equipment and supplies is assessed, and the readiness of the room, completeness of physical setup, and completeness of instrument, suture, and dressing setups are determined. Preventing physical injury includes the use of safety straps and side rails and not leaving the sedated patient unattended. We do not want your sedated patient, especially if they are not under general and they're sort of awake but not really awake. If you leave their side and you have not strapped them down and they reach over to grab something or even to scratch something and they roll off that OR table, not a good thing. So we want to make sure we do that. Transferring the patient from the stretcher to the OR table requires safe transferring practices, so you don't want to hurt yourself as well. And then other safety measures include proper positioning and grounding pad under the patient to prevent electrical burns and shock, removing excess antiseptic solution from the patient's skin, and promptly and completely draping exposed areas after the sterile field has been created to decrease the risk of hypothermia. And nursing measures to prevent injury from excessive blood loss include blood conservation using equipment such as a cell saver and administration of blood products. The circulating nurse anticipates this need, checks that blood has been cross-matched and held in reserve, and is prepared to administer if it is needed. So usually your patients will have a typing screen, typing cross before they go to surgery, just in case they need blood. And some procedures, the doctor may anticipate that they're going to need some blood, so they'll type and cross for like 2-3 units and have them on hold in the OR, just in case they need to be hung. So that is why that is done. And with that, that will conclude chapter 18, which goes over intraoperative nursing management. Do please use your Brunner Suite resources. This is your online tool, and it is listed in your text on page 438. It gives you those NCLEX style questions and other resources. It gives you study guides. It gives you clinical handbooks along with laboratory and diagnostic tests. So please do use those resources. They are very good. And for the NCLEX style questions, there should be 25 for each chapter. Use this as a review tool when studying.